So Dr. Paice is an RN PhD, and she's the director of the Cancer Pain Program at Robert H. Lurie Comprehensive Care Center at Northwestern University, and a research professor of medicine at Northwestern University Feinberg School of Medicine. Much of Dr. Paice's clinical work has been in the relief of pain associated with cancer and HIV disease. She has traveled within and throughout the world to educate healthcare professionals regarding cancer pain relief and palliative care. Dr. Paice served as the president of the American Pain Society from 2006 to 2008 and is currently the secretary of the International Association for the Study of Pain. Dr. Paice serves as the associate editor of the Journal of Pain and serves on the editorial board of the Clinical Journal of Pain and Journal of Pain and Symptom Management, and is the author of more than 150 scientific manuscripts. She is one of the original consultants in the End-of-Life Nursing Education Consortium and has continued serving as a faculty member in this program. Please help me welcome Dr. Paice.
Super. Thank you. Well, welcome everybody. Thank you so much for taking time from your very busy schedules to be here tonight. And thanks to the Foundation for Peripheral Neuropathy and the Wellness Center here for hosting this evening. I want you to get what you need when you leave this evening. So we have a little bit of a more formal type presentation because of the videotaping. So I'm going to speak for about 30 minutes, and then as Pam said, we'll open it up for questions then, okay? So write down your notes and think about what you want to ask once we get to the question and answer. I'm going to use the slides to kind of give us a guide. So we're going to talk about syndromes that occur in cancer pain, and particularly neuropathies, and particularly the peripheral neuropathies. As Pam was talking about, chemo-induced neuropathy is huge, but there are other neuropathies that people with cancer can develop. And we're going to talk a little bit about pharmacologic and non-pharmacologic approaches to manage these neuropathies. So as you can guess, the prevalence of cancer is just exploding around the world. And it's not only a burden in our country that people are developing cancer, but it's around the globe. And the prevalence is expected to be quite high in the very near future. Now, the beautiful thing about the U.S. healthcare system, and I don't want to get into any debates about the Affordable Care System, or ACT or any of those things, or as they call it, Obamacare, we do have a pretty amazing healthcare system. And I have done a lot of work in other countries, and we are so fortunate that we have the resources. People diagnosed with cancer in the U.S. can become long-term survivors and can live with cancer for many, 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 many years. Unfortunately, in other countries, that's not the way things typically pan out. Most people are diagnosed with advanced disease, and they don't have access to chemotherapy and radiotherapy. So you all know, you are the experts at knowing what the therapies are that we have available. We certainly have surgeries, chemotherapy, radiation therapy, hormonal therapy, and each of these can lead to their own pain syndromes. We've known for a long time that surgery can cause post-surgical syndromes, post-thoracotomy pain, post-mastectomy pain, phantom sensations after amputation. We know that radiotherapy can lead to acute pain, mucositis, or changes in the skin that can be painful. Long-term, some radiotherapy can lead to chronic pain syndromes. And chemotherapy, which we're going to be talking a lot more about, can lead to significant prevalence of neuropathy. And we know which agents, and I'll share those with you. And by the way, for some of you who may have had a stem cell transplant, even the transplant can lead to neuropathies, even if they're not using a chemotherapeutic drug that causes neuropathy. We think it has a lot to do with the graft versus host disease that people develop. And then hormonal therapies, which are allowing breast cancer patients to be long-term survivors and people with prostate cancer, but many of these hormonal therapies can lead to bony type pain. So the good news is we have more and more and more treatments available, and so people are living with cancer. We have better survival rates, but the bad news is some of these treatments lead to chronic pain syndromes. And we have kind of some estimates, but the data aren't so great, to be honest with you, in terms of what percentage of people will have cancer pain. It kind of depends on where they did the studies. And the big question mark we have is, what is the prevalence of pain in cancer survivors? The good news is people are surviving. 30 years ago, they didn't. And so we didn't have good statistics then. So you all are our experts. So cancer pain can occur from many, many different causes. And I think the most important message that I want to share with you is that I can't tell by looking at any of you as you're sitting here tonight if you have pain or not. And I'm in the clinic every day taking care of people who have pain. Pain is subjective. You must tell us. That's really the most important message. Communicate with your doctor, your nurse, your caregivers that you're experiencing pain. And I'll get back to that in a little bit, but please don't assume that we understand or know that you have pain. But you can see the many, many different things that can lead to pain in people with cancer. And these are just a few of the examples. We tend to divide pain into 3 broad categories. Nociceptive pain is achy, throbby, bone, muscle. Visceral pain is belly type pain. It's a little bit more diffuse. With musculoskeletal pain, you can point to the site and know where it's hurting. But with the belly, if you've ever had a really bad attack of gastroenteritis or food poisoning, you know that it can hurt pretty much all over your belly, and it can kind of move, and it can be more of a cramping or a stabbing or a squeezing kind of pain. And then the pain type that we're most interested in tonight is peripheral neuropathy, or neuropathy pains in general. Neuropathic pains are often described as tingling, burning, electrical, shooting. For those of you who don't experience neuropathy, first of all, be grateful. Secondly, let me give you an example from everyday life. Have you ever hit your funny bone and you get that weird, sharp, shock-like feeling up your arm? Imagine having that 24/7. Or another example, if you ever fall asleep at night on your arm and you wake up in the middle of the night and your arm's kind of dead, kind of numb, and as the sensation comes back, you get that weird tingling. That's another example of neuropathic kind of pain, to give you a feeling for this. So let's talk a little bit about chemotherapy-induced peripheral neuropathy. I've been conducting several studies in this problem, and one of the requests is we have patients draw out where their pain is located on this figure. And you can see the person on the left is sort of the classic presentation. And Pam mentioned peripheral neuropathy from chemotherapy affects the longest nerves in the body. Well, remember, the nerves that serve the toes and the feet start in the spine. So they go all the way down from the spine to the toes. So those are your longest nerves. Second longest nerves here, spine to the fingers. Third longest nerves start in the spine and wrap around. I've seen just a few people with neuropathy here. And then the fourth longest are from the nerves up to the very top of the head, almost as if you had a little cap on your head. And I've seen one patient who had severe diabetes and chemo-induced neuropathy develop pain up here. The very most common is like the patient on the left. Some patients, though, do experience neuropathy that progresses up and affects larger areas, usually of the extremities. Now, these are the chemotherapeutic agents that can lead to peripheral neuropathy. Now, I usually call this painful peripheral neuropathy because for most people it's painful. Some patients just have numbness. It's not painful, it's just numbness. That can certainly affect their safety, their walking, their sensation, but it's generally not perceived as painful. For most people, they have tingling, burning, it's a feeling of pain, and they may have painful numbness as well. the agents that I see most commonly causing painful peripheral neuropathy are paclitaxel. It's used a lot in women with breast cancer. It's used more and more now with lung cancer and some other malignancies. But it's the breast cancer population where I see this most troublesome because, again, breast cancer has become a chronic disease and people will live many years with breast cancer. The other agent, oxaliplatin, is used primarily for colorectal cancer. And this is a weird one because while you get the infusion, the nurse will tell you, don't drink anything cold. Don't touch anything really cold. In fact, with our Chicago weathers, you really have to bring a lot of scarves and gloves and everything because the cold air will be perceived as painful. And the reason it's so important that you don't drink anything cold is that you might feel severe pain or swelling sensation, an altered sense in your throat that's very difficult for us to know, is this the acute neuropathy or is this a hypersensitivity reaction where you're having like an allergic response to the drug? And the treatment's very different. So with oxaliplatin, people get that acute response. That can last a couple days, and then later, some people develop painful peripheral neuropathy. The other drug that's probably one of the worst is bortezomib, also called Velcade, and this is used principally in people with multiple myeloma. Now, a really interesting thing about multiple myeloma is the disease itself creates peripheral neuropathy. It's such an unusual cancer that the tumor cells secrete substances that cause peripheral neuropathy. So that's what makes multiple myeloma a little bit different as a malignancy. But you can see there are other agents that lead to neuropathies. There we go. Now, the question I always get is, how can I prevent it? And I wish I could tell you that we had really gangbuster kinds of products available or therapies available. Now, this is really about prevention, not treatment. We're going to come to that in a minute. There have been a lot of different studies done, but I will tell you, most of them were really poor. They were either very small studies, they were studies that weren't randomized, they maybe included mixed groups of patients where some got paclitaxel, some got oxaliplatin, so they weren't homogeneous groups of people. And because they were so small, you couldn't really tell for sure. But on this slide are agents that we're pretty sure are not effective. Again, now this is for prevention. Remember, not treatment, prevention, preventing the neuropathy. So, and the challenge with any of these studies, conducting these kinds of studies, is we have to be absolutely sure that if we're giving these drugs at the same time that the person's getting chemotherapy, that whatever drug we work on or develop doesn't diminish the anti-cancer effect of the chemotherapy, right? That would be really complicated. Now here are some, again, back to only prevention, not treatment, potentially promising, but we need more data. Now, calcium and magnesium, I need to say now, that was only for oxaliplatin, and just recently an abstract was published, large, good clinical trial. It wasn't helpful. So it was not helpful in preventing oxaliplatin-induced peripheral neuropathy. Acetyl L-carnitine, another nice study, just published, not effective in preventing paclitaxel-induced peripheral neuropathy. We have a trial of alpha-lipoic acid underway at Northwestern. That's being conducted in women getting paclitaxel for breast cancer. And then some of these others, we're just not sure. Again, the studies are too small. So that's prevention. What a great opportunity, but it hasn't borne out yet. So that leaves us with treatment. And what are our goals of treatment? Well, in the best of all possible worlds, we could prevent neuropathy, right? But if it occurs, we definitely want to relieve pain. That's a quality of life issue. We also want to improve function. Allow people to move, because that is so important to your healing as a person with cancer. The more you're able to move, the better you have energy. It counteracts fatigue, kind of paradoxically. The better your sleep will be. We clearly know that problems with sleep and insomnia are worsened with inactivity. You're better off to keep moving. We know that moving keeps the joints going, keeps the muscles in tune, prevents deconditioning. Deconditioning can lead to pain and discomfort. And safety. And you're going to hear more about safety this evening, because that's a real concern when you can't quite feel the bottom of your feet. So let's talk about pharmacologic options to relieve pain. And I'm focusing specifically on neuropathic pain, the tingling, burning. So the non-opioids, and we basically divide pain medicines into three major categories: non-opioids, opioids, and adjuvant analgesics. And then there's a fourth category, and that would be cancer treatment. If anyone has ever had a bone metastasis, you know that radiation therapy is really stellar in reducing the pain associated with bone metastases. So at times, the treatment itself can be very helpful in relieving pain. But let's talk about the first three categories, and let's start with the non-opioids. These are drugs like acetaminophen or Tylenol, and the non-steroidal anti-inflammatory drugs. These are drugs like Motrin, ibuprofen, naproxen, Aleve, those kinds of agents. In general, these drugs have limited benefit for nerve pain, if any. They can be helpful for bony pain. They can be helpful for joint type pain, helpful for headaches, but not really for nerve pain. And the funny thing is, I worry a lot, even though these drugs are available over the counter, I worry a lot about the toxicities. Acetaminophen is very hard on the liver. And the liver is the organ that helps metabolize many of the medicines that we use, including chemotherapy. So we need to make sure you have a healthy, functioning liver, and we only have one each. So it's not like we've got a spare. NSAIDs, drugs like ibuprofen, have similar side effects, but they can cause gastrointestinal bleeding, ulcers, usually with no warning, by the way. Renal compromise, so problems with the kidneys. And again, we really rely upon our kidneys to help filter out toxins and the toxins of drugs. And then finally, the NSAIDs can cause our platelets to not clump together to form a clot. So if you're on a chemotherapy drug that alters platelet numbers, and then you take one of these drugs, you may have more problems with bleeding. So again, even though they're available without a prescription, they're not innocuous. So what about opioids? Boy, these are drugs that get a lot of attention from the media right now, and they make a lot of people pretty scared, don't they? And yet, these drugs do work for neuropathic pain. And the opioids don't hurt the liver, they don't hurt the kidneys, they don't hurt the lungs or the kidneys or the heart. Now, they do cause constipation. That's why they call me the pain in the poop nurse on the clinic. But for most people, you can prevent constipation, for the vast majority. So I'll sometimes see people who aren't taking their pain meds because they're so worried about constipation, but there are lots of medicines and techniques we can use to prevent that. So opioids are really useful, and these are just a few of the many opioids available. Now here's what happens when I'm in clinic and I'm suggesting an opioid for people. People will say, morphine? Oh no, that's for the very end, isn't it? Well, you know what? When I first started as a nurse, it was 30 years ago. We didn't use these medicines like we do now. And we really undertreated a lot of people. And that's what motivates me to try to do a better job now, because people suffered terribly. Now we understand there's no reason to hold back on these medicines. They can be very effective in relieving all kinds of pain. And yeah, they cause constipation, but we can keep that under control. And the good news is we have short-acting opioids. They usually work in about an hour when you take it by mouth. Usually they last about 3 to 4 hours for most people. And we have long-acting opioids. There's a long-acting morphine pill. You take it twice a day. That gives you some general foundation of pain control. Fentanyl patch, you change it every 3 days. That gives you a constant level of pain control, and you still take the short-acting opioid for what we call breakthrough or rescue. Like you're doing pretty well most of the day, but you and your spouse want to go out to dinner and it's hard to kind of get in and out of the car, or sitting on a hard stool or chair at the restaurant is painful. You can take the medicine before you go so that you're more comfortable, because we want you to get out. Or the person who says going to church or synagogue is painful. Take it before you go to prevent that pain. And like I said, there are side effects. When you first start taking opioids, for many people, you get a little sleepy or fuzzy, as some people say. But for most people, that goes away when you take the medicine regularly. And I have many people who are working, who are highly functioning, taking care of little kids, serving as lawyers, doing everything in between, and they're on opioids and very cognitively aware. The vomiting and nausea occurs early. That tends to go away. Itching is usually something we see again in the operating area, post-operative area, but not long-term. The big side effect is the constipation. And we can make this happen. We can relieve this. So again, talk to your doctor or nurse about that. And then the third category of drugs are the adjuvant analgesics. These are really medicines that were developed for other purposes, but along the way we learned that they're actually very useful for nerve pain. So for example, steroids, dexamethasone, can be very helpful if there's pressure of a tumor against a nerve root. For example, if anyone has ever had a bone metastasis in the spine and they get that shooting pain down the leg, some people will call that like a sciatic kind of pain because of the pressure against the nerve root. Well, the steroids help calm that pain. Anti-epilepsy drugs like gabapentin or pregabalin. Gabapentin is Neurontin, pregabalin is Lyrica. These are the bread and butter of pain control for neuropathic pain syndromes. Antidepressant drugs, and we've got older ones like nortriptyline, which is also called Pamelor. That one tends to make people a little sleepy, so if I'm working with someone who's having trouble with sleeping at night, I'll usually use that one because they sleep a little bit better. And we know that sleep helps your overall mood, helps you to feel better overall. And if you're stressed and fatigued and tired, that's going to actually make your pain worse. So we'll use medicines to help relieve the pain that are sedating, or if sleep isn't a problem, the newer agents like duloxetine, which is also called Cymbalta, very useful in the relief of neuropathic pain. We can use local anesthetics, although they're somewhat limited. We don't have really any oral local anesthetics, but you can take topical formulations of lidocaine, and that can help for short periods of time. And then the question always comes up about cannabinoids, marijuana, especially now with Illinois having passed the Medical Marijuana Act. My own clinical experience with patients who use marijuana is that it's very helpful for appetite, and it's very helpful when people have anxiety. It helps to calm that, particularly if people have formerly used marijuana recreationally. Their body seems to be accustomed to it. The worst thing is when I have a well-meaning adult child who maybe grew up in the 70s, kind of like I did, and maybe they've got their 80, 85-year-old parent and they decide to make them marijuana brownies, and their 85-year-old mom has never had marijuana before, and then all of a sudden we get some very interesting reactions. Now, that's a little bit humorous, but the good news is there is actually some research looking at more refined compounds. because actually smoking marijuana, even, it's not clear how Illinois is going to enact this law. It really doesn't become active until January. But even smoking anything, whether it's been regulated or purchased on the street, has a high probability of being contaminated. And the last thing we need right now is to have our lungs damaged further through smoke. So there are people looking at sprays and vaporizers and other kinds of things that look kind of interesting, but the research is not complete. Okay. Now, there are lots of different routes of administration. If pills are problematic for you, again, make sure your doctor knows that you're having trouble swallowing, because we have liquids, we have patches, we can put certain medicines under the tongue. Some medicines are being developed for nasal delivery. So lots of clever and creative ways we can get the medicine into your body. For the vast majority of people, though, the oral route is the simplest, the easiest, the cheapest, and the best. Now, the question always comes up about integrative treatments, and Julian will probably mention a little bit of this too. I find that acupuncture is something that many people like to try, and I think it's worth a try. There is one really good study that looked at acupuncture for the bony pain of the hormonal therapies that women with breast cancer get, and there was a statistically significant improvement. And there are studies underway now looking at acupuncture for peripheral neuropathy. So I've had many people try acupuncture. For some it's helped. For others it didn't really help their pain, but they felt more energy. They felt maybe better appetite. And I had one gentleman, he told the acupuncturist that not only did he have pain, but he was having bad constipation. And they put a needle in an area here, and he would reliably have a bowel movement after every acupuncture treatment. So you never know what acupuncture might be able to help you with. I am also a very strong advocate of yoga and Tai Chi. Yoga is a little bit more invigorating, so you have to be clear that if you've got any problems with instability, that your yoga teacher knows what those problems may be. I take a yoga class, I go every Monday night, and I've been doing it for about 8 or 10 years, and I have to tell you, I broke my leg skiing in the spring, and I don't think I would have been able to manage those crutches without having the strength that I had gotten from my yoga classes. So yoga is wonderful. If yoga is a little too invigorating for you, a little too hard on some of your joints or bones, try Tai Chi. That's another excellent way to do stretching and exercise. Again, exercise, I can't say enough how important it is. Physical measures like PT, OT, and Julian worked in a clinic where it was specifically designed for people with peripheral neuropathy, and they had a physical therapist or occupational therapist to help people ensure that they were standing appropriately. One of the things with chemo-induced neuropathy is you lose something called proprioception. If you have this neuropathy in your feet, you don't necessarily feel where your feet are. Normally, when you're walking, you're not having to think heel, toe, or look at the floor. But especially when there's no visual cues, like when it's dark, like at nighttime on your way from the bed to the bathroom, you can fall. So a physical therapist, occupational therapist can help you build up collateral muscles to compensate, but there are also some safety measures that you're going to hear about that are also important, like night lights, checking the temperature in your water heater, because you don't want to draw a bath and stick your toes in there, because your toes aren't going to sense how hot that is and you can burn yourself. Cognitive behavioral therapies, and you're going to hear more about that in the second presentation. Again, really important techniques. So as you talk with your doctors and nurses, I really can't stress this enough. Think about before your meeting, because most of the time you get like 10 minutes, right, in your clinical appointments. You want this to be efficient. Where is the pain? When does the pain occur? How intense is the pain? We tend to measure it using 0 to 10. 0's no pain, 10's the worst. For some people that works. For some people it's a little too conceptual. Just say mild, moderate, severe. And it's helpful to know, well, it's mild right now as I'm sitting here talking to you, but most of the time it's really into the medium or severe phase. Or I'm fine when I'm sitting, but it's severe when I'm standing. All of that information really helps us to discern what's causing this pain and how might we do a better job of managing it. What are you currently taking? I ask all new patients to bring all their pill bottles, even things that they maybe stopped using. I just saw a lady this morning who's a very, very bright lady, but she had a bottle of ondansetron and a bottle of Zofran. Now, what's the problem with that? It's the same drug. One's the generic name, one's the trade name. She was inadvertently taking an extra dose of the medicine. So there are lots of safety things related to medicines that can be overwhelming. We ask patients to become pharmacists, nurses, and physicians, managing these complexities that no one in their right mind should have to deal with. And then, what have you tried in the past, even if it wasn't related to your current illness? I had dental work done 3 years ago, and they gave me this drug, and it really didn't work. It gave me bad side effects. So tell us. Or I had this medicine when I had my gallbladder surgery, and boy, that worked really well. Tell us. Why should we reinvent the wheel? Actually, why should you have to reinvent the wheel? Because you're the one who's going to be experiencing benefit or risks. And then, have you ever had reactions to pain medicines? For most people, they don't have allergies to opioids. But many people, the very first time they're given morphine or oxycodone or hydrocodone, many people get queasy. That's not an allergy, that's a known response. And we can prevent that by using anti-nausea drugs. And generally, after about 2 days, that nausea feeling goes away. So let us know when you're having pain. Keep a diary. You're going to hear more about that. Bring your pill bottles to the clinic. Don't store your pill bottles in the bathroom medicine cabinet. This is the dirty side of our world right now. We're having a bad problem with diversion. And if you have anybody coming into your home, a cleaning person, a repair person, a landlord, friends of your friends, that you don't really know these folks very well, addiction is a real powerful problem. And if someone is addicted and they see that you have narcotics or opioids in your house, they will steal them. Real estate agents in Chicago know of this scam, and they tell their clients that if you have an open house, get these medicines out of the medicine cabinet. It's the first place they look. They'll have an open house, a couple will come, or a pseudo couple. One person will distract the real estate agent, the other one makes a beeline for the medicine cabinet and steals the medicine. I educate everybody about this now. For a while, I was getting a call almost every week or every other week from my patients about medicines being stolen. I had a patient just this year who had a Super Bowl party. She had just family members. They were all supposed to use the powder room, not her bathroom. And at the end of the party, there was her OxyContin. Cap was half off, half the pills were gone. So not only was she out of her pain medicines early, which means she'd have to pay out of pocket for them, which is not cheap with OxyContin, but now she knows someone in her family has a bad addiction problem too. So that's really important. And then when you're finished with your pain medicines, dispose of them appropriately. We really ask not to flush them down the toilet anymore, because we are finding levels of antidepressants, oral contraceptives, and all sorts of other medicines in our water supply. There are take-back programs. There's actually a national take-back program twice a year, April and October, just passed. City of Chicago has an ongoing take-back program where there are designated police department offices where you can bring your medicines, no questions asked. They incinerate. That's what those take-back programs do. So you might want to ask your local police department. Many of the pharmacies will take back the medicines, but they usually won't take back narcotics. And some of the pharmacies will sell you a special envelope. So you have to pay to take back. So use your resources. So I've spoken for about 30 minutes and you're still awake, so I applaud you all at the end of a long day. Questions. I really want this to be your time.
Will you repeat the question?
Sure. Yes, sir.
With the advent of genome sequencing, there are companies now that claim to be able to take a cheek swab and look at a half a dozen genes that you have and be able to select which analgesic is best for you. What's your opinion on that? Fact or fiction, and do you have any experience with it?
It is a little bit of both. So we know, for example, that there is a group of people who don't metabolize codeine. Codeine is the active ingredient in Tylenol number 3, or it comes by itself, codeine. Codeine is called a prodrug. It doesn't provide pain control on its own. It has to be broken down in the body. And about 10% of Caucasians, 3% of African Americans, and 3% of Asian Americans don't have the enzyme to break down codeine. And so what happens in the clinical setting is the patient will say, I just took that medicine and I don't feel a thing. And I'm sorry to say that 30 years ago, you know how we responded to that patient? Oh, really? You probably want something stronger. So now, I'm being a little facetious, now we know, at least that particular drug, we know that a certain group of people shouldn't have it. In fact, I never prescribe codeine anymore because of that.
That's different than hydrocodone?
Hydrocodone is a different compound than codeine, yes. Codeine is the only one really that's a prodrug. Now, we haven't perfected the tests for the other drugs to know you do well with morphine, you do well with hydrocodone, you do well with Dilaudid, and you do well with, fentanyl. We haven't gotten that far. So there's a little bit of truth, but not yet full utilization of these genetic kinds of tests that are done for cancer patients with looking at tumors. From the analgesic side, it's not as developed yet. Other questions? Yes, sir.
Have you done any studies on the STEM treatment, the electro shocks through the fingers and toes?
Okay, so the question is, have I done any studies on electrical treatments for the fingers and toes? So there are a couple different electrical kinds of treatments. The oldest one that's been around forever and ever is called the TENS unit, transcutaneous electrical nerve stimulation. And that's been used for, I remember it being used 25 years ago. And we used to place these electrodes. They kind of look like an electrode. You might have an EKG. They could be even more rectangular. We used to place them like next to surgical incisions when people would have a procedure. People are testing it for low back pain. For neuropathy, the challenge is it seems to only work while you have the electrodes in place. So you'd almost need an electrode glove and an electrode sock. And that probably wouldn't be safe for walking. So really hasn't been effective. There is a new technique that is sometimes called the scrambler, and it's being studied in University Mayo Clinic. It's being studied at University of Wisconsin-Madison, and it's being studied at Medical College of Virginia. Now that is also electrodes placed in the area, but not necessarily in the exact spot of the neuropathy. And they are finding that some people are getting prolonged benefit from that. But there was one very small sham study where they compared the real treatment to kind of a fake treatment, and the patients weren't sure which they got. It was very, very small, and they didn't see a difference. So it would be so cool if we had really good therapies that weren't drug-related therapies. People are working on it. Yes, ma'am.
Is there any drug out that would give you comfort of neuropathy in the mouth?
So the question is about neuropathy in the mouth. One would try, I would say, any of those adjuvant analgesics that were listed here, all the same. It doesn't really matter where the neuropathy is. But neuropathy in the mouth is quite unusual, and so I'd want to find out what is the underlying cause of that. And so that's something that you and your doctor would need to work together. Is it something that's reversible? I'll give you a quick example. People who have stem cell transplants will have graft versus host disease sometimes, depending upon the kind of transplant, and they'll get mucositis or sores in their mouth, and that will feel like neuropathic kind of pain, and we can use steroids to relieve that. So thank you for asking that question. Yes, ma'am?
You covered a lot of ground. I took a lot of notes, but just to be so basic, how do you treat neuropathy of your hands and feet, which I have it.
Sure, I would suspect lots of folks in the room do. So we would start, usually, every patient is different, so every person is different. So as a general rule of thumb, we try to start with the adjuvant agents, drugs like Neurontin or Lyrica. And when we start, one of the major mistakes I see is people will come to me and say, I've tried Neurontin, it didn't work, but they only started at the 100 milligrams 3 times a day, or even 300 milligrams 3 times a day. Those are very low doses. And as long as you've got good kidney function, we can go up on the dose quite a bit higher than that. In fact, the original clinical trials of gabapentin or Neurontin, they were testing diabetic neuropathy and post-herpetic neuropathy, which is shingles, another kind of nerve pain. They used 3,600 milligrams a day of Neurontin. So there are some people who should never get that high a dose, and clearly we don't start there because you'd be a bowl full of jelly. You know, the usual side effect of Neurontin and Lyrica, they're very, very similar drugs, is that they can make you kind of feel a little bit dizzy and a little bit sedated. That's why we start low and work up. Now, people with more complicated neuropathy may need an anti-seizure medicine like Neurontin. They may need an antidepressant medicine like Cymbalta. They may even need an opioid. That's called multimodal therapy. So for people with more complex neuropathy, we need to attack it from different angles. I hope that answered your question, at least broadly. There was a hand back there, and then I'll come back. Well, I guess, go ahead, ma'am.
I have 2 questions.
Uh-huh.
Are opiates addictive?
Excellent question. Want to start with that?
Can you repeat the question?
The question is, are opioids addictive? There is so much misunderstanding about that. The people who become addicted to these medicines are people who already have risk factors for addiction. So people who are pretty heavy drinkers, people who are chronically using recreational drugs, people who have a strong genetic risk, in other words, lots of biologic family members with alcoholism and drug use. And ironically, the other group of people who are very much at risk for addiction are people who have been sexually abused as preteens. It's a very strong risk factor for any kind of addiction. So for the vast majority of people that I see in clinic, they're not going to become addicted from these medicines. They don't have these risk factors. For people who do have risk factors, we talk about it. And we talk about, here are the risks and benefits, and we're going to watch your medicine use. We do a lot of tough love and a lot of education. It's really important, for example, not to use your morphine or your opioid to sleep at night. You can take it for the pain that you're having in the nighttime, but don't take it to make you fall asleep at night, because you know what's going to happen? It's not going to work after a while. Your body gets tolerant to that sleepy effect. So, and it's also not a good idea to use it to treat your mood. And that's where I see people running into trouble. That's also different than addiction. Did that answer your first question? Good.
The second one is, I have tingling in my hand.
Uh-huh.
Now, I have neuropathy in my feet.
Uh-huh.
I don't really have pain with it, but they feel kind of numb. But I don't have anything in this hand.
Mm-hmm.
But this hand, it's all tingling, and they were thinking it was carpal tunnel.
Mm-hmm.
And I also have neuropathy.
You have lymphedema, don't you? Yeah.
Edema
Yeah.
in my arm.
So,
They can't really do
right.
some of the testing.
And you don't do a carpal tunnel procedure. So the question is, she has some numbness in her feet, and only on her right hand, which I notice you have a sleeve, so you have lymphedema on your right hand, but you don't have neuropathy on your left hand. So that's likely not necessarily chemo-induced neuropathy in your fingers. That may be related to the lymphedema. And I would encourage you to see a good lymphedema specialist
That's the problem.
for massage therapy and things like that.
I've been to physical therapists who, do the manual drains.
Yes,
and all that.
uh-huh.
But I haven't found a doctor that really knows in this area.
So if you are, the question is looking for a doctor who knows lymphedema. If you can get downtown, I'm sorry, I don't know the suburban resources, but at the Rehab Institute of Chicago, there are several physical medicine and rehabilitation doctors who specialize in cancer rehabilitation.
Okay.
And I'm gonna ask you if I don't want to talk about specific cases per se, so you and I can maybe talk offline at the end. How's that? Okay, I can give you some names and things. Other questions? Yes, sir.
I have two questions. The first question is, what is the connection between the chemo treatment and PN?
Okay, so what is the connection between the chemo and the development of peripheral neuropathy? If I could answer that question, I would win the Nobel Prize. But no, it's really, I like your analytical thinking. And I spared you the basic science work, but there are some, it's really wonderful, some basic scientists who are studying this in rodents, and it seems to be a problem with the mitochondria in the cells. The mitochondria, if you'll remember from your basic physiology, is sort of the powerhouse of the cell. And if the nerve doesn't have its power, it can't do its business. And what's the business of the nerve cell? Transporting neurotransmitters back and forth, up and down the long axons. And that seems to be part of the issue, at least one of the hypotheses, but we don't know for sure. But that's going to be our first step to really developing prevention and good treatments.
But do you see that the sheath around the nerves is breaking down?
No. No,
There's
not really.
No connection there.
No, the question was, does the sheath around the nerve breaking down? That doesn't seem to be the major cause. The mitochondria become vacuolated and sort of blow up, and that seems to
You
be.
just see that in chemo patients, they have neuropathy, and we don't know the connection.
Well, it's actually being done, the research is being done in rodents because most patients don't want to donate their nerves for study. I would commend you, Dr. Gary Bennett at McGill McGill in Montreal is a wonderful university. He's publishing a lot, so you can Google him and you can see some of his
What
publications.
about radiation therapy? Do you see the same connection?
No, radiation therapy, the effect on radiation is probably a little bit more, on the nerves, is probably a little bit more direct and not chemically related per se, and we don't know for sure.
Is it unusual to have radiation therapy and 30 years later develop what's called idiopathic PN?
So the question is it unusual to have radiation and then 30 years later develop this problem of peripheral neuropathy? I've not seen that in my practice. I have seen people who have had radiation therapy and 10 years later develop bony changes, develop fistulas depending upon where the radiation therapy was administered. Like if the bowel was involved, sometimes you see problems with the bowel breaking down. I've seen the bones break down, like in women who have had radiation for cervical cancer. Sometimes the heads of the femur fail. But I've never seen just peripheral neuropathy occur. Other questions? Yes, sir.
We have a couple of drugs that were derived from the vinca plant that can cause peripheral neuropathy. There's a supplement called vinpocetine also derived from the vinca plant. Any chance at all that could be a cause of peripheral neuropathy? To your knowledge?
So you've asked a really good question about vinca alkaloids, drugs like vincristine and vinblastine. Those were some of the oldest ones that we knew caused neuropathy, and they were typically used more in children. And you're asking if there are supplements that are kind of based.
Supplement called
Yeah.
vinpocetine. I wonder if there's any chance that you've heard of that.
I don't I've never seen it being suggested as a treatment for peripheral neuropathy, and we really don't know about a lot of supplements what adverse effects they can cause. I will say that there is more and more attention to other drugs causing peripheral neuropathy, like the statin-type drugs may, for some people, and some of the fluoroquinones, which are antibiotic-type drugs. Ciprofloxacin is a real common one, for example, seem to lead to peripheral neuropathy. So in the person with cancer, we blame it on the chemotherapy, and that's likely the major driver, but there are probably other factors that add to it as well. I think I have time for one more question.
Sure.
Yes, in the back.
Do you see PN in pediatric oncology patients?
Yes, in fact, with these early drugs, the vincristine and vinblastine, which were used for childhood leukemias and young adolescents, they would develop neuropathy. But remember, it's only since like 1960s that we've been curing leukemias where people lived. So, yeah. And children probably have a little bit greater capacity to heal. We used to teach, by the way, that nerves didn't grow, but we now know that they do regenerate, but they regenerate about 1 millimeter a day. That's about the width of your hair. So if you imagine that you've got this long nerve extending from your toes all the way to your spine, that's like about a yardstick at least. 1 millimeter a day is pretty slow regrowth. I hope I answered all of your questions. I want to thank you all so very much for being so attentive, again, at the end of a long day. So I appreciate all of your help. Thank you.
Thank you, Dr. Paice. And Dr. Paice will be around to answer questions afterwards. I just want to say a couple things before I introduce Dr. Breslow. Anybody that's out of treatment for cancer, or folks that don't have cancer in this room, maybe have idiopathic or diabetic neuropathy, it is really important that you see a neurologist to treat your neuropathy. Try to find somebody that specializes in the peripheral nerves. There's many neurologists out there. There's a lot of patients that see them, but they don't get any really good treatments from them. Again, there's no cure, but there's management of your neuropathy. They can help you. They can work with your dosaging of the dosage of the medicines that you're taking. So it's really important that you find one. We funded a program at Northwestern called the Foundation for Peripheral Neuropathy Clinic. They have wonderful doctors there that specialize. They do research in peripheral nerves. So double check to make sure the neurologist you're going to has some knowledge in peripheral nerves. Also, to answer your question about medications, there's a great document on our website that talks about all the different medications that doctors treat patients with neuropathy and different dosages, and you can take that, print it, and take it to your doctor and ask him about it. And it was that document came from Johns Hopkins. So we work with well-known scientists at Johns Hopkins. They provide a lot of great information and resources that you can find on our website.